I was asked to give a talk on maternal near miss, preventing maternal mortality. And so I thought to divide my lecture into half talk and updated information about maternal near miss, and then some case-based discussions if time permits. So, if you, it is said that if you want to know how strong a country's health system is, just look at the well-being of its mothers. So, maternal health is an integral part of a country's healthcare system and the third sustainable developmental goal. One, it reflects status of obstetric health. Second, it helps in reviewing achievements of the facility or the country. Third, it assists in comparison between different countries and different regions of a country, and it helps in setting up of new goals as well. So for ages, conventionally, maternal mortality used to be as an indicator of maternal health. So looking into the trends in the maternal mortality annually, like around, unfortunately, 99% of the maternal mortality still occurs in the developing world, with developed countries only giving 1% contribution to each. And as per the WHO fact sheet of 2019, India stands quite high in the maternal mortality of 145. And even though that is around 12% of the global maternal deaths. And even though there was a healthy trend, that is a decline of 3.5% seen in the maternal mortality rate in India over the years, still we are far away to achieve the Sustainable Developmental Goal 3 of 70 per lakh maternal mortality ratio. So various reasons have been ascribed to this, like health expenditure is very less of percentage of the GDP. Some say half-hearted government efforts are there. Then there are very many challenges which are on the social, economic, political, and attitudinal fronts. So maternal mortality is a health indicator. It's a sentinel event. It is judged by maternal mortality ratio, that is the number of maternal deaths per 1 lakh live births. Maternal death review was first launched by Ministry of Health and Family Welfare in 2010. However, now it is not considered sufficient enough to evaluate the obstetric health in isolation. When we analyze the causes of maternal mortality, it occurs mainly in otherwise healthy individuals. So why is it? So high risk obstetrics is a challenge. In practice, you must be seeing that. So pregnancy itself is a high risk condition. So the critically ill parturient is always a challenge because of the complex homeostatic physiology in the pregnant state. Not one but two lives are at risk at the same time, and there is significant contribution to maternal mortality, especially in countries like India. So maternal mortality is just the tip of an iceberg with a vast base, the maternal morbidity, that remains undescribed and relatively unevaluated. So this, when things go wrong in obstetrics, they go wrong really fast and they fall off a cliff. So there is a continuum of morbidity, mortality, severe morbidity, near miss, and death. And if we target this near miss population, then we really go a long way to avert the mortality. So with this, the concept of maternal near miss came into vogue. So women who experienced and survived a severe life-threatening condition during pregnancy, childbirth, or the postpartum period, they are considered as the near miss cases or the severe acute maternal morbidity as first defined by Say et al. In 2009. So these cases, they share many characteristics with the maternal deaths. They can directly give information on the obstacles that actually have to be overcome at the onset of an acute complication. And if corrective actions are taken for these, they can reduce the related mortality and long-term morbidity. So maternal near miss has emerged as an adjunct and proxy measure to identify the gaps in maternal health services over the period of time, and they act as complementary to maternal mortality. So WHO defines the maternal near miss as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. And Ministry of Health and Family Welfare in 2014, they gave certain operational guidelines also, which I'll be coming to a little later. So there were many criteria for identification of MNM since the concept emerged. There was Geller criteria, there was Mantle criteria, which was organ-based dysfunction, Waterstone criteria as well. But then we recommend the WHO criteria, which first came in 2011, and based on which the Ministry of Health and Family Welfare gave the operational guidelines in 2014. So WHO recommended three approaches. This is disease-specific criteria, the management and intervention-based criteria, and the organ dysfunction-based criteria. So the disease-specific criteria like severe preeclampsia and eclampsia, severe hemorrhage, severe sepsis, and uterine rupture. Then management or intervention based, like admission to ICU. So a patient who goes to ICU, she is near miss. Procedures like obstetric hysterectomy, massive blood transfusion, any patient who undergoes intubation or needs ventilatory support. So these are the intervention based criteria. And then the organ dysfunction based criteria. So these are based on the apparent clinical diseases, clinical markers, and management needs. So aim is towards the correction of that organ dysfunction to arrest the near miss progression to maternal death. For example, a patient can have serious respiratory, renal, coagulation dysfunction, or hepatic, neurological, or uterine dysfunction. So this is considered the most promising frame for establishing a standard set of criteria. So this is really very important, and it also is helpful in the low resource settings like ours. So WHO first gave these criteria in 2011 in 2000 the near miss criteria, and then the Indian recommendations for diagnosing MNM came by the pilot study in 2014. So for identifying the case as MNM, minimum of the three criteria, that is the clinical findings, investigations, and interventions, were done. And the criteria were divided into three groups. Again, the pregnancy specific medical or obstetric disorders, pre-existing disorders which were aggravated by pregnancy, and the incidental or the accidental disorders. So, or any patient who had any single criteria that signified cardiorespiratory collapse. So she fit into the definition of maternal near miss. Now, then there are some process indicators of maternal near miss. So these are based on the concept of criteria-based clinical audit. So they are considered feasible method of auditing quality of maternal health care and useful for assessing deficiencies and lacunae between the actual use and the optimal use of high priority interventions in prevention and management of severe pregnancy complications. So the MNM indicators commonly used were SMAUR, then MNM ratio. So SMAUR was the severe maternal outcome ratio. That is the number of women with the life-threatening conditions, that is near miss plus maternal death per 1,000 live births. So this gives an estimate of the amount of care and the resources that would be needed in an area or a facility to optimize the maternal outcome. Then is the MNM ratio. So number of maternal near miss cases per 1,000 live births. So this gives an estimation of the amount of care and resources that would be needed in an area or facility again. Then maternal near miss mortality ratio, and which shows that a higher ratio, that means there are better care being provided. And then it was the mortality index, that is the number of maternal deaths divided by number of women with the life-threatening conditions expressed as a percentage. So mortality index is the maternal deaths divided by maternal near miss and the maternal death in combination as the denominator. So higher the mortality index, the more women with life-threatening conditions die. That is, low quality of care is being provided. Whereas the lower the index, that is lesser the life-threatening condition women, they will die. So that means that gives an assessment of the better quality of care. So why are we discussing this? Why are we reviewing the maternal near miss once they happen? So the process of maternal near miss review is important because again, it tells us a lot of things about the healthcare being provided by a small facility or a large facility. So the process includes identification of MNM cases, notification to the medical officer or the head of the department, data transmission, then review at the institutional and the district level, and then an analysis and feedback for necessary action. So what are the advantages of MNM review? So the near miss cases, as we know, they are more common than the maternal deaths. So they provide an adequate information and analysis. They are rare enough not to overload the clinicians and data collection personnel within a facility. But due to higher number than the maternal deaths, they provide more statistically reliable quantitative analysis and more comprehensive profile of functioning of the healthcare system within the facility. Secondly, the maternal near miss, they share the same pathway and pathological processes as the maternal mortality, as I've already discussed. So the major reasons, the causes are the same for both. So if untreated, near miss can lead to maternal mortality. So we can gauge that also. Thirdly, less threatening to the service providers. In case of maternal death review, health professionals and other stakeholders involved in the service delivery are often fearful that the blame would fall on their shoulders. They consider the maternal death review process as a potential threat to expose them to public scrutiny and outrage. Investigating the incidence of maternal near miss review may be less threatening to providers because the women survived. But a maternal near miss review, fear of blame and punishment is less, and the healthcare professionals, they are more willing and eager to share their success stories because it's a pat on their back that they were able to save one life. Learning from the maternal near miss survivors, women themselves, once they survive, they are available for the interview about the care they received as opposed to maternal death. They share their experiences in ICU, psychological devastation and trauma they faced during the process. Their psychological perspective can also be gauged, and information about the social and family problems and lack of awareness of healthcare facilities can be gauged as well. And then we can come to the level of delays, which is very important again. So, this significance of maternal near miss review in reducing maternal mortality, because it is simpler to analyze, easier to resolve, and this appraisal, when used in conjunction with the maternal death review, will aid in recognizing the patterns, the trends of maternal morbidity and mortality, identify the contributing factors, aid in evaluation of quality of healthcare, facilitate detection of lacunae in existing system, and help in setting up of a database to capture the all locations and facility details to identify where a near miss case comes from, and this would help us focusing interventions in a particular location as well. It also gives a fair idea about the requirement of healthcare facilities in terms of infrastructure, human resources, and interventional facilities, gives a comparison of the existing healthcare and the optimum healthcare. It identifies delays at various levels and identify modifiable socio-demographic factors responsible for the maternal and morbidity and mortality, and also helps us stands very handy in the international comparisons also. So this is the facility-based near-miss review form, which was given by Ministry of Health and Family Welfare in 2014, and this was used, and this is being used for near-miss audit in our hospital as well. And again, it has three, as I've already told, it has underlying disorders at admission. It gives a fair idea of the patient's condition at the time of admission, type of admission, whether she was a referred case or a walk-in, status at admission. Then her antenatal history is recorded, and whether or not she has not received an antenatal care for reasons, any past history, what were her chief complaints. Then the examination findings, then the investigations, the delivery details, the mode of delivery, any complication which would have occurred during that time, then her purpurium, post-abortal, post-laparotomy status, and blood transfusion. Details of blood or component transfusion, details of the baby are included, and the systemic involvement if it was an organ-based dysfunction, and the condition at time of discharge in this patient. So then there is another column which we also record regularly every in each shift. Our HDU residents, they keep on recording. These are the intervention details at places from where referred and at the institution. So we can record the institution one more accurately. So whether the patient required ICU, whether patient was intubated, whether she underwent other resuscitative procedures or have assisted mechanical ventilation, any use of cardiotonics or vasopressors in a patient, emergency evacuation had to be undergone, or patient underwent laparotomy with procedures like stepwise devascularization or internal artery ligation. She underwent hysterectomy, manual removal of placenta, reposition of inverted uterus, repair of genital injuries, management of ketoacidosis. She undergoes dialysis because of a AKI. She receives anticoagulants and then drugs to reduce cerebral edema as well. So these were then we also, to identify the level of delay, we capture the information like the personal family history, logistics, whether there was any lack of transport between health facilities, lack of infrastructure at the referral facility, and also the present facility details. Then the form is signed, filled, signed by the resident on duty, and cross-signed by the consultant on call. So this was now what the M&M says. I have talked about the maternal near miss and the near miss reviews. So when I searched for the latest evidence, so there was a systematic review of the prevalence of maternal near miss, which was given by O. Tunkal, which concludes that there is a growing interest in the application of maternal near miss concept as an adjunct to the maternal mortality. The literature published before 2011, there was a still important variation in the criteria used, but once WHO gave the 2011 criteria, these were used as the benchmark, and then they help us in comparing the rates over time and across regions. Also, WHO maternal near miss approach and the maternal severity index models, the tools for assessing management, have been used in various studies worldwide. Then the evidence in Asia Pacific has also been analyzed, and there is a meta-analysis which is available, which states, again, it concludes it was done because to monitor the rates of severe maternal morbidity in the Asia Pacific region. And then these are the maternal near miss guidelines, which establish maternal near miss as an indicator for maternal health and maternal care, which became operational in December 2014. And then there are many studies of maternal near miss events in India which were given, and this was one of the latest which I could found. And this is a small summary of various studies which are done on the maternal near miss, applying the WHO criteria and the maternal MOHFW guidelines criteria. And they have all found that hemorrhage is still most common cause of maternal near miss in our patients. And if we tackle it well, as we all go in all the conferences these days, so we can really avert the maternal mortality, because it is one of the major preventable causes. And then determinants of maternal near miss events among women, they have also been admitted to tertiary care hospitals. They've been studied on a very extensive and comprehensive worldwide, including Africa, Southeast Asia. And then maternal near miss audits have been done, reviews have been given. So this was a small review about the maternal near miss. Where do we stand today, and as compared to maternal death review. And based upon this, I have got like around maybe 2 cases to discuss. And so if you permit, I can go ahead with this, ma'am. So the first case was like Mrs. X. She was wife of Mr. Y, 23-year-old primary gravida, resident of South Delhi, a homemaker, 8 pass, and unbooked case. She presented in an emergency of our hospital. She was not sure of dates. She was referred to Safdarjung with high BP records and history of 7 months amenorrhea with complaint of headache since 1 day and bleeding per vaginum for the last 10 hours and pain abdomen with absent fetal movement since then. So the bleeding was sudden in onset, dark red in color, associated with pain abdomen. No prior history of such episodes. She soaked 4 to 5 pads fully since then. She could not perceive these fetal movements after the onset of pain abdomen. She also gave history of headache since 1 day, which was continuous and throbbing in nature. She went to some private clinic before that with her complaints, where she was told to have high BP, and she was referred to a higher center. There was no blurring of vision, decreased urine output, or epigastric pain, and there was no breathing difficulty or chest pain. Her trimester history was otherwise insignificant, though quickening was felt at 5 months amenorrhea. She visited a hospital at present complaints only, and there were no other antenatal visits. She underwent a scan level 2, and it was normal as per her. Obstetric history, she was married for 1 year, non-consanguineous, and this was her first pregnancy, which was spontaneously conceived. So past history and family history were again insignificant. She was vegetarian by diet and taking around 1950 kilocalories per day as per the recall method, and she was a lower middle class. She was belonging to a lower middle class family. So on examination at Safdarjung, she was conscious oriented, well oriented to time place person, and her BMI was 23.2. Her hydration was adequate. She was afebrile to touch. Pallor was present. There was no icterus. Her pulse was 96, regular, good volume. All pulses were palpable. Her blood pressure was 178 by 112 millimeters of mercury in right arm in left lateral position. Repeated after 5 minutes again was 172 by 116. Her respiratory rate was 22 per minute, and her saturation on room air was 98%. CVS, both heart sounds were audible. There was no murmur. No abnormality was detected in CNS, and urine albumin was done with dipstick method in the GRR itself, and it was 3+. On per abdomen examination, she had a uniformly distended abdomen, all quadrants moving equally, and the fundal height was 24 weeks. She was obviously not corresponding to her period of gestation, and her abdominal girth was 22 inches. Basal tone of uterus was increased. Mild tenderness was present. The fundal grip was suggestive of head, and pelvic grip was suggestive of breech. So fetal heart sound could not be localized on auscultation. And on local examination, a pad was soaked, active bleeding was present. First speculum was done, os was 1 centimeter, blood mixed liquor was coming out. And so the provisional diagnosis was a 23-year-old primary gravida at 7 months with severe preeclampsia with APH, most likely abruption with intrauterine fetal demise and breech presentation. So I would like to present this case for the open house discussion. So how would you manage, ma'am? Anyone, if you would like to take it?
Let's ask our experts.
Yes, ma'am.
Yeah, Hannah. So experts, Dr. Sangeeta. Would you like to comment on this?
Dr. Divya, Ms. Sangeeta.
Good afternoon. Uh,
Divya.
so, so this patient definitely needs to be admitted immediately
Yes, ma'am.
and preferably in an HTU setting where we have to start her immediately with an IV drip, blood grouping, cross matching of blood would be required, her coagulation profile, her kidney function test, liver function test, Foley's catheter to be inserted, and all consents taken, things explained, counseled, the attendants counseled about her high risk, being high risk, and blood should be started as soon as possible after getting the hemoglobin, CBC, etc. done, and she needs to be started. Like you've already written, that we need to, of course, monitor her very closely, which includes her blood pressure, her heart rate, her respiratory rate, her PO2, and of course her urine output. And immediately we start her, because she had a high blood pressure, so we start her on antihypertensives, and labetalol injections would be the best thing. Seizure prophylaxis, you've written, should be given. She's already an IUFT case, so as soon as possible termination should be planned, and an ARM should be done, and if possible, so that we can stop further in concealed bleeding. And then induction to be done, and patient should be delivered as soon as possible, and taking care of her vitals and the rest of it, like you've written.
Good, Dr. Divya. ARM was not required because she was already leaking.
Yes, ma'am.
So yes, she has to be managed very, very closely. So can we have any other expert commenting on it? Dr. Renu Manchanda, if you are there.
Ultrasound should be done to rule out concealed hemorrhage.
Yes,
And
ma'am.
I think blood and availability of blood and blood products is very,
That's
very,
right.
very important
ma'am.
in this case, because
Yes,
that
They
is
have to
the
be.
only life-saving measure, early delivery as well as availability of these blood components, which can blood and blood products, which can save the life of this patient.
So keep an eye on
Likely
DIC
to go
also.
into
We have to keep
DIC,
an eye
so
on
we have
DIC
to
as well.
monitor all the
correct, ma'am.
parameters very closely.
Yes, ma'am. So, ma'am, this patient was managed very well, just like as you stated. And then her pre-delivery investigations were this, which showed an LFT OT of 178, PT was increased to 50, and her KFT was 36, and zero point 0.9 was creatinine. Serum electrolytes were 128, 4.6, and her HB was 8.1, TLC was 20,500. But platelet count was significantly reduced to 55,000. She had spontaneous onset on labor while she was being investigated, and she got admitted. She had preterm breech vaginal delivery. She delivered an FSP IUD girl baby of 750 gram. A 300 cc of retroplacental clot was removed. Placenta and membranes were delivered completely. There was no PPH. She received 2 units of packed RBCs. The maximal maintenance dose was continued 4 hourly after checking the knee jerk, the respiratory rate, and the urine output. But the last 3 doses were withheld due to absent knee jerk. Serum magnesium level was done, though they were normal. So then her postnatal period, as you stated, that she was being watched very carefully. So at day 0, she was monitored closely with these frequent vital charting, and any bleeding from vagina. Antihypertensives were continued, and relevant investigations were being collected. Ultrasound KUB was done, and as ma'am you already stated, that even her intake output charting was very important. It was done in view of her, but her creatinine was rising in this patient. So on day 1, we started the antibiotics, as urine routine showed plenty of pus cells and presence of bacteria. And she was also treated for hyponatremia and hyperkalemia, which was diagnosed on the ABG and serum electrolyte measurements. Then on day 2, the renal function was monitored with serial KFT and serum electrolytes. And on day 3, 1 unit packed RBC was again transfused. But in view of a rising creatinine value, we thought of taking a nephrology consult. So, ma'am, can you highlight anything like what do you think that she is going into in her postnatal period?
This is acute kidney injury.
Yes, ma'am.
So that has to be managed by diuretics and accordingly, according to the creatinine levels, if required, dialysis could be done.
Yes, ma'am. So, ma'am, her input-output charting was this, which showed that on from day 0 to day 2, her output was decreasing, and day 3, it was decreasing quite further. And when we look on a trend of investigations, we could really see that the creatinine was gradually rising. So, if you concentrate on the KFTs, so 1.3 was on day 0 of delivery, and then it was 3.1 in the morning, 3.3 in the evening, then 4.1 in the morning, 4.7 in the evening, and then on day 3 went to 4.9 as well. So at that time, because we had sought for a nephrology consult, she underwent a hemodialysis, and then post dialysis immediately it resolved to 3.2. So this patient, she became a near miss, but timely intervention, close monitoring, and timely institution of all the therapies and termination as well was quite helpful in saving her life. An ultrasound whole abdomen and KUB was also done, which showed that uterus was postpartum, bilateral adnexa were normal, but the right kidney was swollen, raised cortical echogenicity was there, and left kidney was no calculi, no hydroureter nephrosis, and left-sided mild pleural effusion with maximum depth of 2 centimeter was noted. So, any comments or any this on a further management, ma'am?
I think it was very well managed, and we all should learn from this that in case a patient is going into acute kidney renal failure, then we need to call the renal specialist, nephrologist, and if the patient requires dialysis, she should get it done. In private practice, we hesitate to get everything, anything done because we feel that the patient's attendants will start getting worried and kind of, making a noise about it. But
Yes,
we
ma'am.
have to be absolutely clear about this.
Yes, ma'am.
One thing I wanted to clarify, Dr. Shiva,
Yes, ma'am.
that you said magnesium sulfate maintenance dose was continued.
Yes.
But
No,
magnesium
no,
sulfate,
ma'am.
doesn't it get
Last
stopped
week,
once the delivery occurs?
No,
ma'am,
24 hours.
Should be
after
continued for
24 hours
24
of the
hours.
delivery, and the last 3 doses were withheld because the levels were rising, knee jerk was absent. So we got the levels also done, and they were but normal. So we didn't need any antidote as well.
So including her in the near miss criteria becomes her renal impairment,
Yes,
means
ma'am.
organ failure as far as
Yes, ma'am.
kidney is concerned.
Yes, ma'am.
And in all this shows that in all the cases of severe PIH and abruptio placentae, we have to have a very careful monitoring as far as renal functions are concerned.
Yes, correct, ma'am.
Because we have
Because
faced these type of problems in severe
yes, ma'am.
preeclampsia as well as along with abruptio.
Yes, ma'am. At many
But
times we
I
see a
think, we
resident
have to
saying
also see the fluid correction
balance.
properly because this lady had an ascites also as well as pleural effusion.
Yes, ma'am. Correct, ma'am. So, ma'am, because the residents, they often feel elated and on duty, being in floor that, okay, ma'am, the blood pressure is controlled. We have delivered the baby, and the mother is fine now. 750. The retroplacental clot also has been removed. But then, careful vital monitoring is very important, especially in the first 72 hours of such patients, because the actual insult it might occur at that time. And since we really reiterated on the vital charting and the electrolytes and the KFT reports, which were serially being monitored because the creatinine was rising, so we could pick up this acute kidney injury in time and refer her for a hemodialysis after a nephrology consult and save this patient.
In a similar case, Shiva with us in the hospital, we suspected the problem of renal failure because she had edema around her eyes, acute edema around her
Yes,
eyes,
ma'am.
which made me susceptible. Why so much of edema on face? There is no cause.
Yes, ma'am.
And then she turned out to be a kidney failure, and then we have to do the hemodialysis and everything in this patient. Of course, patient went home in a healthy state.
Okay, ma'am.
No,
So
no,
that was
here
the
this-
name. Yes, ma'am.
Here I just want to wish to tell you is that we have to have a very uniform policy across
Yeah.
maybe say
Yes, ma'am.
Delhi level. That
Yes, ma'am.
whenever you have a patient who comes with anemia, who has severe hypertension, and who has been accidental hemorrhage, there's a good retroplacental clot of 300, though she started the serum creatinine of only 0.9, but her urine output has to be very closely monitored, the strict intake output chart. And the serum creatinine has to be, all these functions should be there. Criteria should be 3. It is not that, she's just delivered, shifted to the ward. If you shifted the ward, the all is done.
Yes,
But
ma'am.
I think, she requires a very close follow-up in such cases So at least acute kidney injury is somehow picked up early. I think
Yes, ma'am.
that's the very message.
Yes, ma'am. So, ma'am, going ahead with the second case, a 30-year-old second gravida, previous one cesarean, with no live issue, with IUD and polyadraminos
Your
at
screen again, Dr. Shiva. Your screen
Hanji,
is
ma'am.
going.
I'll repeat
Share
again.
your screen again.
Yes,
No,
ma'am.
share your screen again.
Okay, ma'am. Ma'am,
अच्छा, पता नहीं।
is it visible, ma'am?
Okay.
ठीक है.
So, 30-year-old
Yeah,
G2P1L0, previous cesarean with IUD and polyhydramnios at 36 weeks of gestation. She was admitted from our OPD. She was a known case of gestational diabetes on oral hypoglycemic agents. She was taking metformin. So, after initial investigations and arranging blood, she was started on TAP mifepristone because she had IUD. And after 5 doses, she had onset of labor, and the labor progressed spontaneously. She delivered a macerated stillborn baby girl, 2.8 kg. IM oxytocin was given. Placenta was not separated till 30 minutes. Senior obstetrician on call was informed. The OT team and anesthesia was informed, and she was rushed to the OT. So, ma'am, any idea of this case being because she was a previous LSCS with IUD, polyadraminos, admitted because with gestational diabetes for termination. So, any thing which is pointing towards the diagnosis for her being a near miss at this time?
Yeah, there must have been a scar rupture, and while
No. Why scar rupture?
Placenta was not being separated, ma'am. So she was.
Part. It should be, placenta accreta.
Yeah.
Morbidly adherent placenta.
Yeah.
okay, placenta accreta, yes.
Yeah. Adherent placenta. Placenta is not coming out. The problem is placenta.
Yes, ma'am.
PAS.
But ma'am was also partially right because while shifting to the, she was immediately rushed to the OT, and while shifting to the ultrasound, the patient collapsed. Then she was confused. She appeared her tachycardia was increased to 120 pulse, blood pressure fell to 60/40, respiratory rate was 26, SpO2 was 90%. Her shock index was 2 and quick SOFA score was 2. So clinically she was just 6 to 7 grams, and initially she was resuscitated with an IV large bore, 2 IV large bore cannulas in IV fluids, oxygen and catheterization. On per abdomen, the uterine contour was not maintained and distension was present. And ultrasound was done which showed fluid, and the placenta was in situ, and the continuity of the anterior wall of the uterus was lost. So she was rushed to OT because she was a case of ruptured uterus, and an emergency laparotomy was performed under GA. And through the previous card, the rupture was there. It was a uniconvex uterus, so that's why I presented this case. So the placenta separated spontaneously thereafter. The rupture was repaired, and a tonic because she did not have any live issue before that as well. And a tonic PPH occurred. Medical management failed. Then stepwise devascularization was done. Bilateral internal iliac artery ligation was done because every effort was to save her uterus. And she received around 6 units packed RBC, 6 unit PRP, and 6 unit of FFP. So, ma'am, this patient she was shifted to ICU. She was started on inotropic support, and then further no more transfusion was required. On day 2, however, she improved. She was extubated. Inotropes were stopped after being de-escalated. On day 4, she was shifted back to her obs ward, and on day 10, stitch removal was done, and she was discharged in an alive condition. So she was a real near miss, and she became near miss. If any of the experts can give comments upon.
In a very atypical way, previous cesarean section, the previous live child suddenly presenting with macerated baby.
No previous live child. Previous not live.
No
Previous live child nahi tha, ma'am.
Okay.
Previous LSCS, no live issue. Currently also she came with IUD, polyhydramnios. She was diabetic and she was admitted for termination. So she was an actual case which was presented.
So whenever we are dealing with a case of previous LSCS, we have to keep this in mind that she may either be a case of PAS, PAS, or she may be going into a scar rupture during delivery. So one has to be extremely careful. In fact, any previous LSCS who's coming to us for antenatal at about 30 weeks, we have to get her an
Ultrasound
ultrasound
with
color
Dr.
doctor
Dunn.
done
Yes, ma'am.
to exclude PAS, and then again we have to get it done every 2 weeks so that we are able to actually diagnose the condition of PAS. And never take up case of previous LSCS, even for an elective cesarean, unless we know we have ruled out PAS.
Correct, ma'am.
In
Absolutely.
this case, presence of
It means, with previous cesarean section, even if there is an IUCD, mifepristone should not be given.
Okay, ma'am.
But in this case, polyhydramnios may be again a cause for excessive distension of uterus, and
Yes.
because which might have lead the slow dehiscence of the uterus. Polyhydramnios. So presence
Yes,
of polyhydramnios should have made us more careful and vigilant about the vaginal delivery. And secondly, she went into shock pretty fast after a good delivery. Means there was
Yes,
no
ma'am.
difficulty in delivery. There
Yes,
was only
ma'am.
placenta problem is there.
Placenta was not being separated, and she was at that time she was being shifted for ultrasound room to detect what happened, and by that time only she collapsed.
So we have to follow the same rule that after delivery of a cesarean section, whether we should explore the uterus for any scar dehiscence or not. As in this case, there was placenta is not yet delivered, so we had to have a strong suspicion in mind that there can be a problem with the placenta. And I
ma'am.
think this PPH.
No, but the triggering factor has been the mesoprost. Why
No,
doses?
No, madam, misoprost means mifeprost. Madam,
given, ma'am.
these days we use mifeprost
Mifepristone. Yes,
to make the cervix softened and favorable for the delivery.
Yes, ma'am. Ma'am, now
In
we
IUD cases.
in a patient with scarred uterus, and if she has IUD, then mifepristone is the drug of choice. We
Yeah.
give mifepristone 200 milligram TDS, that is 600 milligram OD, that is recommended for 48 hours, and then we give rest to the patient. And then she, mostly the patients, they go into labor after say about 3 or 4 doses only.
News to me.
So, ma'am, this was like the rupture patient, and patient had a rupture after being delivered vaginally. So that's why she collapsed, and then she was resuscitated, and then she was shifted to OT, and then an emergency laparotomy was performed. So she became a near miss because of that. Then she had a massive blood transfusion. She became
a near miss of that.
that
Yes.
also, and she underwent stepwise devascularization. She underwent bilateral internal artery ligation. She was on inotropes, so that way she was a near miss as per the.
And I think she must have been shifted to ICU, so that
Yes,
also
ma'am.
is
She
an
was shifted
indication.
to ICU. She was started on double inotropes, and then after this she was de-escalated, and slowly she extubated on day 2, and then she was shifted back to ward and discharged in a stable condition on day 10.
And any other investigative disorder?
Ma'am, if time permits, I can share another case. If you say, ma'am, she's a 35-year-old G3P2L1 who was referred to emergency at 35 weeks of period of gestation with severe anemia and complaints of shortness of breath, fatigue, and swelling in her feet and legs for the last 2 days. Her history, there was a history of breathlessness on exertion for last 10 days, but now even at rest, she was having the same. She had no history of cough, asthma, chest pain, hypertension, or fever or contact with a COVID-19 patient. She had history of breathlessness 3 days after last delivery 2 years ago, for which she was admitted to the local government hospital for 2 weeks, but she did not follow up after that. On examination in the casualty, her blood pressure was 130/86, her pulse was 120 beats per minute, her respiratory rate was 40 breaths per minute, which was labored. Her SpO2 was 89% on room air, her raised JVP was there, pallor was present, grade 3 pitting edema was there on bilateral lower limbs up to the knees. Chest bilateral air entry was present, but there were fine crepitations bilaterally especially on the bases. On CVS examination, apex beat was heard, and but there was no added sounds or murmurs. And per abdominal examination, she had 34 weeks uterine fundal height, and fetal heart sound of 160 per minute. Her relevant investigations which were there, a CBC of HB was 7.2, TLC 6700, platelet was 1.4 lakh, her KFT 34, blood urea, serum creatinine 0.8, LFT was 0.9, Bill 46 and 45 were the OT and the PT. Her chest X-ray was also done, which showed cardiomegaly with bilateral pulmonary infiltrates, and an ultrasound showed a single live fetus of 32 weeks with an AFI of 6. So this was the echo report which was done of the patient, which showed us that there was dilated left atrium, right atrium. There was global hypokinesia, thin rim of pericardial effusion was present, and left ventricular dysfunction was there. And she had moderate MR, and the IVC also showed normal inspiratory collapse. So left ventricular ejection fraction was 38%. Her ABG showed pH of 7.4, PO2 64, NT-proBNP was raised to 5747, ECG showed sinus tachycardia. So this was a case of acute dyspnea in pregnancy. So ma'am, anyone if wants to enlighten us with the differential, what were kept in mind for this case till now?
So this patient is going into CCF,
Yes,
and
ma'am.
probably due to cardiomyopathy.
Yes, ma'am.
She basically needs a cardiologist's opinion, who would
Correct,
be the
ma'am.
person to tell us exactly what is the pathology with her. But it is a cardiac pathology.
Yes, ma'am. So, ma'am, this was a critically ill patient, which was a near miss because she came into an emergency and we could diagnose her everything in time, and she underwent an echo, and then because she was going into failure, so as after the consultation with the cardiologist in our heart command center, we took her for cesarean section, and then she could survive, and then she stayed in ICU for like around 3 days, and then she was extubated, and then she was discharged in a stable condition. So this was actually a peripartum cardiomyopathy which was diagnosed at this time. So this again became a near miss because she underwent she had an ICU admission because of her cardiac failure. So this was
So
like a
here is the
cardiac.
role of multidisciplinary team in this case.
Correct,
No
ma'am.
obstetric problem with the patient, but the related other cardiovascular problem was with the patient. So we have to have a good setup with dealing such type of cases.
Correct, ma'am. So multidisciplinary care, including the cardiologist, the anesthetist, obstetrician, neonatologist, and this is called as the pregnancy heart team now. So that is important. And then we have to, and also anticoagulation was started, and this was in collaboration with all our anesthetists and cardiologists, we could save this patient.
So I think, this how to monitor with the shock index and all this small monitoring, that only clinches the diagnosis that something is wrong very seriously with your patient. And
Yes,
that's why
ma'am.
everybody
So
has
that's
to
why the importance, ma'am, comes of the obstetric warning scores and
Correct.
the early warning scores, the modified obstetric warning scores, which helps us to pick up the patients which need more monitoring than the usual ward patients. And even if they are shifted to HDU, then also if they are in the yellow zone, so that means we need to change or alter our treatment because they might go into the red zone quite quickly. So that's why the scores are very important, and our charting is very important in this. So the SOFA scores, the warning scores, the early warning score, they are very important in this.
Yes.
Yes, ma'am. So I would like to conclude this that the maternal near miss review is an eminent adjunctive strategy to help identify gaps in the health service provision. The M&M review and the MDR review, they are complementary to each other. They cannot exist independently. The current MDR format is not equipped to gather information on those pregnant women who delivered through complications and just about averted mortality, where the M&M cases aid in taking measures for further amendment of the service delivery and programs. So whenever used together, they would help in recognizing the contributory factors of maternal deaths so that appropriate actions can be adopted at both the community and the health system level. So the carry home message is that M&M is a vital tool that can go a long way in reducing the maternal mortality. So the life of a woman is not easy. She not only has to take care of herself, but of everyone she knows. Tragedies are always in her path, and it's our responsibility, being her doctor, to give her a safe motherhood. So thank you, ma'am, for patient hearing and giving your vital inputs. Thank you once again.